Thank you, Tor. Yeah, thank you very much. It's an honor for me to be here. But it is actually somewhat daunting to speak to such a distinguished crowd of aortic surgeons about the medical management of aortic disease. But there are things I want to discuss today important in the medical therapy. First is establishing an accurate diagnosis of the underlying disease. I'll discuss the pharmacological therapy, the importance of lifestyle modification, and the long-term surveillance. As Diana mentioned, there are many disorders associated with thoracic aortic aneurysm, and sometimes the features overlap markedly, and the diagnosis can be changed. So when I see a patient who has an unexplained aneurysm, it's very important to look for the red flags in the patient's history. But often it's much more informative when you get the history of another family member as opposed to the patient that you're seeing in the office, because sometimes the features in a family member will be much more striking and will inform the diagnosis for the patient that you're seeing. So when I ask about the patient, I ask about the family for features of an underlying disorder, genetically triggered, and I ask, do other family members have these features? And the same thing goes on the physical exam. The patient may have more minor features, but another family member in the room or elsewhere may have much more striking features, for instance, of Marfan syndrome from an FBN1 gene mutation, as opposed to the patient that you're seeing. The same thing goes with features that should make you think about Loeys-Dietz aneurysm syndrome due to a different gene, or features consistent with a familial aneurysm syndrome. So now I'm looking at patients differently. I'm having them undressed almost fully to see, do they have levator reticularis? Do they have a history of premature coronary disease or cerebral vascular disease or moya, or a PDA alone? In the imaging of patients with aneurysm syndrome, sometimes serendipitously we'll find dural ectasia. And again, in an aneurysm patient, this should send a red flag that this is a familial or genetic syndrome associated with a gene defect, abnormal dura leading to expansion of the dural canal in the sacrum. These are sometimes called Tarloff cysts. So you look for these features in your aneurysm patients to give information about the underlying disorder. And the pattern of aortic dilatation may also provide clues. When the root's involved and the sinus is involved, it's typically one of the gene defects such as Marfan syndrome or Loeys-Dietz syndrome, whereas in bicuspid valve disease, the aorta is more often enlarged distal to the sinuses. Or if when the patient has arterial tortuosity, ectasia of branch vessels, dissection at small size aortas, branch vessel dilatation or dissection, or very early and rapid expansion after aortic dissection occurs. Think about Loeys-Dietz syndrome, a much more aggressive aneurysm syndrome. In all patients with thoracic aortic aneurysm disease, controlling hypertension, smoking cessation, and treating hyperlipidemia is recommended. There are theoretical benefits to the pharmacological therapy based on lowering aortic stress and potentially anti-inflammatory properties, but there's really very little data in humans on the medical therapy of thoracic aortic aneurysm disease. Much of the information comes from mouse models or mechanical models. Beta blockers are the background for thoracic aortic aneurysm disease based on the hemodynamic benefits and the effects of lessening the stress and strain of the rate of rise of pulsatile force on the aorta. And this theory, and based on work in hypertension and aortic dissection and in mechanical models, led to the rationale for use of this 40 years ago in Marfan patients because of the benefit in malignant hypertension patients by reducing the rate of rise of blood pressure. The contractile strength of the myocardium and the strength of the pulsation is important in the progression of dissection, and beta blockers can lessen this effect and be effective in the management of aortic dissection. And that in turkeys prone to spontaneous dissection or aortic rupture could have improved survival when beta blocker was added to their feed. This paper, published now 17 years ago, looked at Johns Hopkins at the Marfan patients, young patients treated over 10 years with beta blocker with high doses of propranolol versus placebo, and in the patients treated with beta blocker on the lower aspect of the graph had a slower rate of rise or slower slope of aortic growth on average compared to the untreated patients. They also had fewer aortic dissections. So the most recent thoracic aortic disease guidelines do recommend beta blocker therapy for Marfan patients to reduce the rate of aortic dilatation. But it's a mouse model of Marfan syndrome and other syndromes which are providing the insight into the basic pathogenesis of these diseases. As Diana said, fibrillin-1, the abnormal protein in Marfan syndrome, and the microfibrils regulate TGF-beta, the family of growth factors influencing many aspects of cellular performance. And in fibrillin-1 deficient mice, the Marfan mouse model, there's excess TGF-beta activation and signaling in the tissues involved in Marfan syndrome. And angiotensin also has an important role in TGF-beta signaling. And angiotensin-1 receptor blockade with the ARB drug losartan can induce decreased TGF-beta signaling. One can measure decreased TGF-beta levels, decreased TGF-beta responsive genes, and decreased mediators in this signaling cascade, including matrix metalloproteinases, giving a target for potential therapy in Marfan syndrome and potentially other disorders. Haldeep's group examined this in the mouse model, showing a striking benefit in Marfan-treated mouse with losartan, preventing aortic aneurysm formation, and importantly, restoring normal histology to the aortic wall in Marfan mice treated with losartan compared to beta blocker or placebo, which had marked cystic medial degeneration. In a group of young patients treated by Hal and his group with rapidly growing aortas despite beta blocker therapy with a mean Z-score of 7, ARB drugs were initiated. And once that was done, there was a marked reduction on the rate of change of aortic root diameter in this very aggressive Marfan aortic group, with the mean diameter changing to only 0.5 millimeter a year growth compared to 3.5 millimeters a year prior to the initiation of an ARB drug. There are many trials going on around the world looking at ARB therapy and Marfan syndrome. The U.S. study is a Pediatric Heart Network study. It's finished its enrollment. It'll be completed in about 2 years. And these studies should help to understand what the role of ARB drugs for the natural history or treatment of Marfan syndrome. TGF-beta activation may be involved in other aneurysm syndromes. As Diana mentioned, it could have a role in, certainly in Loeys-Dietz syndrome, potentially bicuspid aortopathy, and familial aneurysm syndromes perhaps. But there's very little or no human data on TGF-beta activation and treatment of TGF-beta activation with drugs in these aneurysm syndromes. There's a study ongoing with enrollment, the BAV study in Canada, looking at an ARB drug, telmisartan, versus atenolol versus placebo. It's actively in recruitment to try to look and see if this therapy will change the aortic root dimension in bicuspid aortic valve aortopathy patients over a 5-year follow-up study. One small study of ACE inhibitor therapy in Marfan syndrome from Australia, patients on standard beta blocker therapy, randomized to perindopril, an ACE inhibitor, versus placebo on top of beta blocker therapy. And the ACE inhibitor group did show benefit with a decreased rate of aortic root growth over a half a year, and decreased TGF-beta levels, decreased MMP levels, and a decreased arterial stiffness in a non-invasive elastic study. Other drugs in thoracic aneurysm disease have even less data, really no data in humans as far as long-term therapy. Doxycycline, but its benefit on decreasing MMP activity, shows benefits in abdominal aortic aneurysm disease and in mouse models of Marfan syndrome in preventing aortic root aneurysms. Similarly, statin drugs have benefit in abdominal aortic aneurysm disease and on tissue samples. Pravastatin showed benefit in a mouse model of Marfan syndrome in lessening aortic aneurysm, but no data on doxycycline or statin drug therapy in thoracic aortic aneurysm disease in people. Lifestyle modification is a critical aspect of thoracic aortic aneurysm disease management. It's important to inform the patient, his family or her family, and the physician that an aneurysm is present and is necessary for long-term follow-up and serial imaging. They should also know about the symptoms of aortic dissection and what to do if that symptom occurs. There are physical activity and work guidelines and recommendations that are important to emphasize. Individuals who have thoracic aortic aneurysms and genetic syndromes are restricted from participation in most competitive athletics. So you have to ask about the job requirements, the specifics, and the type of isometric activity and other sport activities the individual wants to partake in. The Bethesda Conference gives guidelines on the participation of sports and exercise for individuals who have thoracic aortic aneurysms and syndromes associated with aneurysms, prior aortic dissection, and prior aortic reconstruction, limiting the activity to really very mild activities without potential for bodily collision. I saw this patient this week, and I learned from Diana just now that I should be testing for an ACTA2 gene mutation. This is a 22-year-old man who came to see me for an unexplained 6.2 centimeter thoracoabdominal aortic aneurysm. And on review, he did have a type B dissection. But interestingly, he had a history of severe untreated hypertension and practiced intense weightlifting, could bench press 250 pounds with repetition. He didn't have any features of connective tissue disease. So Diana will be sending you a sample. Studies of bodybuilders have demonstrated marked increased systolic blood pressure during maximal weightlifting, even more so during this with a Valsalva maneuver. Dr. Eleftheriades has compilated a series of aortic dissections in weightlifters, heavy lifting, or strenuous activity. Some had a family history of aortic disease. Almost all were ascending dissections, and when the aortic size was known pre-mortem, it was almost always dilated. So individuals who have thoracic aortic aneurysm disease should be counseled against heavy, repetitive isometric activity or isometric activity at a certain level. Pregnancy is also important in thoracic aortic aneurysm disease, but most of the data comes from Marfan patients. These patients are at high risk when the aorta is enlarged more than 40 millimeters or if there's a prior aortic dissection. So a multidisciplinary approach to management is important with serial imaging throughout the pregnancy and counseling pre-pregnancy. But there's very little data on the risks of pregnancy after successful aortic root replacement in these individuals. We presented 15 patients who had aortic dissection from the IRAD database. And when considering women of childbearing age, this represented 12% of dissections in this population. About half occurred during pregnancy, almost all in the third trimester, half were postpartum. The type A dissection pregnancy patients all had dilated aortas, but the type B dissections often had very minimally enlarged aorta or a normal appearing aorta. And 11 of the 15 women did have a recognized connective tissue disorder or aortopathy recognized, usually post-dissection. Once an aneurysm is discovered, imaging of the aorta is critical over time and after surgery. With a newly discovered ascending thoracic aortic aneurysm, an echocardiogram to evaluate for an underlying bicuspid valve is important. Depending on the size of the aorta, repeat imaging over 6 months to document stability may be important, and at least annual imaging, again, depending upon the absolute size of the aorta, the age of the patient, other factors, the disease present. If the aorta is growing more rapidly, of course, imaging more frequently is important. After a dissection, imaging frequently, especially over the first 2 years, is important to look for rapid growth of the aorta. It's important to make an accurate diagnosis of the underlying disease associated with thoracic aortic aneurysm. And for some individuals, this requires mutation analysis. And as Diane has emphasized, we should screen first-degree relatives of the affected individual for coexistent aneurysm disease. Beta blocker is recommended for patients with Marfan syndrome, and in patients with aneurysm of any cause, it's important and reasonable to reduce blood pressure with beta blockers and ARB or ACE inhibitors to the lowest level tolerable. ARB drugs are the subject of multiple trials in Marfan syndrome, and the results of these trials may change the natural history and certainly the treatment of these disorders. Lifestyle modifications pertaining to pregnancy, weightlifting, exercise, and work must be considered. And individuals with thoracic aortic aneurysm require long-term surveillance of the aorta before and after surgery. Thank you very much.